Us of this topic.
Thank you.
Opening
Hello.
batsman.
Hello. Thank you, madam. Thank you for kind words. And thank you, LOCS, Lucknow OBGY Society, for giving me opportunity again. Because it has taken me 9 years to born again in Lucknow. My last visit was on 17/4/2016 at Hotel Renaissance. Even Ram has to take 600 years. For me, 9 years is okay. So with the blessings of mother of mine and so many seniors, the book written by us is recommended as a royal reading material in RCOG. Atlas of Fetal Echocardiography has gone for second edition. Likewise, IVF made easy. I am editor-in-chief of Indian Journal of Obstetrics and Gynecology. Those who are researchers, those who want to publish their work, it is a Scopus recognized journal. So it is index journal. And if you want to go abroad internationally, I am also editor in Open Access Journal in Gynecology. This is a Michigan publication. Last year, actually, I got opportunity to interview Professor Herman Tourne, and this is my YouTube scanner. You can have all the presentations of mine in YouTube regarding gynecology, obstetrics, and IVF and infertility. Today, we are talking something regarding threatened miscarriage. Everybody knows what is threatened miscarriage. When bleeding starts without pain, cervical was closed before 20 weeks of gestation, common complication of pregnancy. Approximately 20% of women undergoing threatened abortion is coming to you, and you have to treat those patients. Out of 50% has to go for permanent miscarriage or complete miscarriage. Approximately 50 to 70% of miscarriage are associated with chromosomal abnormality. For that, we can't do anything. We can't do anything, madam, for chromosomal abnormality. We can't change the genes. Just like your is XS and mine is XY. Why, madam, you are very much stable, you know? Because you have got 4 legs. X. 4 legs. And now question regarding why male are deviating. Genetic abnormality, madam. What we can do? It is 3 leg only. So sometimes it has to move here and there. Joke apart. There are so many causes of miscarriage regarding chromosomal abnormality, uterine malformation, maternal infection, intrauterine infection, endocrine coagulation disorder. Most common is why embryo is rejected. There is very good paper published by Clark and et al. In 1999 that why did your mother rejected me? And that based on the immunological determinants of response to environmental selection. That's seen under the microscope and seen what is seen in the tube. It is the uterus desire, want to continue the pregnancy. It is embryo's desire, want to continue the pregnancy, or it is both desire. We all know that we are all are born from X and Y from our mother and father. But if you see the regression analysis of factor, why multivariate logistic regression analysis says what is most important for the causes of recurrent and threatened miscarriage is serum progesterone. If serum progesterone is less than 35, then the P value is 0.001%. Second term is maternal age, then BMI, and then gestational age. This all compromises the causes of recurrent miscarriage. We are all born from one sperm and one ovum. Okay? Sperm is sometimes looking as an antigen to mother. In COVID, we all know antigen-antibody reaction. Everybody, even common man knows I have to develop coronary or corona antibody because I am taking the vaccine. So many times what happens? This uterus recognizes this sperm as an antigen and it develops antibody against that antigen. And that response is known as allogenic immune response to paternal antigen. And there is lot of study done by Professor Raj Raghupati and all that why there is immunological determinants, why mother is trying to reject you. Because so many times sperm considered as an antibody, and these are the causes in which we can't explain to our leg. We all know second MBBS and globins, everybody had learned. Whenever any infection comes, there is activation of T and B lymphocytes. Okay? Against that antigen, there is antibody development. There are 2 types of pathways, TH1 and TH2. Okay, everybody agrees? TH1, that is younger brother, it is not good. It is not allowing pregnancy to continue. So we have to thank Almighty that our mother has generated enough amount of TH2 cytokine. That is small brother. TH2. That's why there is a protective immunomodulation occurring to the human body. That's why you all are here. And now we have got drug which is giving Th2 cytokines more in our body, protective cytokines more in our body, and that is dydrogesterone. If there is Th1 cytokines thought to be detrimental, then Th2 cytokines are very good. They are protective cytokines. If you see the theory, Th1 has got 2, 12 and 18. These all are bad. Likewise Th2, 4, 5, 6, 6, 10 and 13, these all are good. There is a very good balance between these two. Whenever pregnancy occurs in a lady, it is an immunocompromised state. Pregnancy is like, otherwise, if suppose I want to give you my kidney, you will accept it? No. But why sperm is accepting in the any type of the uterus? That's a big mystery. It is also antigen. But because of immunodeficiency state or immunosuppressed state, we all are here in this world. And we are all are here. We have to thank our mother, and our mother has generated enough amount of progesterone. It is the hormone which requires for pregnancy to nurture. But since the genesis of ossipils, Pincus has designed ossipils, ethinyl estradiol plus progesterone. Till that there is any change in estrogen composition, ethinyl estradiol remains same. Now you see lots of variety of progesterone occurring in market. Norethindrone, 19-testosterone, hydroxyprogesterone, desogestrel, dynogest, drosperinone, dydrogesterone. Then question arises, why? Why this type of so many progesterone has to evolve? Or why there is 1, 2nd, 3rd, 4th generation of progesterone? Because this is the hormone which is nurture us. And those nurture us, the things which has got highest side effect has got maximum effect. All the symptoms of lady who is undergoing pregnancy or undergoing any ossipils, the nausea, vomiting, they are all coming because of the progesterone. To nullify that effect of progesterone, there is different varieties of progesterone available in market. And that progesterone is utmost necessary to nurture the pregnancy. That's why its name suggests progesterone. And corpus luteum is generating enough amount of progesterone to nurture us. My mother has not taken any progesterone to nurture me, or so many mothers of here, they have not taken anything. But once you know there is deficiency of progesterone, here is the progesterone which can give you the same effect of in vivo progesterone, and that is dydrogesterone. That dydrogesterone is giving increase in the PI, that is pregnancy inducing blocking factor. Now we talk about Th1 cytokines. Why Th1 cytokines are harmful? When there is activation of Th1 cytokines, there is formation of symmetrical antibody. There is formation of interleukins, they are detrimental for the embryo. There is formation of increase in the natural killer cell. We have to thank again our mother that our mother has not generated all these things. And if this is there, nobody in this world is going to survive. That's why God has given immunomodulation to the uterus. So there is activation of Th2 cytokines, and Th2 cytokines give 3 positive effects. One, they form asymmetrical antibody. So they are not just like lock and key mechanism. There is formation of protective cytokines. There is formation of decrease in the natural killer cell. So these all characteristics or the blocking antibodies are there. And according to one study, the women with history of recurrent abortions have got significantly lower proportion of asymmetrical antibody, 3%, compared with healthy women, they have got 29% of IgG. When you remember antibodies, GARD, GAMD, G is good, Gujarat is always good because President is from Gujarat, Health Minister is from Gujarat, even your Rajyapal is from Gujarat. So G is always good. Once you talk about M, that is Manish, always bad. It shows active infection, just I am infecting all you are not allowed to sleeping anybody. Moving there, who is sleeping, I am talking with her. So this is a molecular mechanism of progesterone as an immunomodulatory agent. Progesterone, if you give progesterone as a chronic exposure, immunoglobulin cells, P receptive positive cells are there in body. Professor in 2009, Al-Jabe has done very good study that with increasing dose of dydrogesterone, there is increasing number of P receptor positive cells from 10, 20, 30, 40, and that study was published in 2009 in the World Endocrinological Congress. Same way, Simonetti has done again big study that if you are taking the P receptive positive cell in the first trimester, now let's look this P positive receptor cell in the cord blood. So I had taken the cord blood, those who had taken dydrogesterone, They've taken the cord blood, those who have doesn't taken the dydrogesterone. And they've seen that in the patient who had taken the dydrogesterone, T receptor positive cells are very good. That's why nowadays, madam, extended dose of dydrogesterone up to 34, 36, particularly in the preterm labor and in the endometriosis also, and in the IUGR and PIH also. So this is the extended role of isopid you can market in your marketing techniques. And recently we got paper published from Raj Raghupati in the prevention of preterm labor with extended use of dydrogesterone up to 34 weeks of pregnancy. Everybody agrees that micronized vaginal progesterone, if you put into the vagina 400-800 milligram, it will prevent preterm labor. Yes, paper is proven by Professor Nicolinius. So if micronized is working in the same way, why not dydrogesterone? Everybody knows from where dydrogesterone and micronized came. Who is the mother of these two molecules? It is a Discoria villosa. It is a plant origin. It is available in India, Nepal and China. We have to proud that dydrogesterone is somewhere available in Himalayas. So it is a plant origin. Discoria villosa is the plant. From that you are taking the procata. If that procata was marketed by madam in a micronization process, then it will become a micronized progesterone. When that procata is allowed to break the bond, either by UV light, by chemical bonding, or by any other way you want that progesterone to make the retroprogesterone, it is a dydrogesterone. So if you think that micronized is natural, then dydrogesterone is also natural. If you think dydrogesterone is synthetic, then micronized is also. Because both are Ram and Lakhan from the same desert. Because I am near to Ayodhya. Okay, so this TH1, TH2 cytokines in addition, when there is a TH2 cytokines developed, there is decrease in the natural killer cells. I am talking, you are listening. It doesn't mean that I say dydrogesterone is good and you believe that dydrogesterone is good. Today, in a court also we have to put some evidence. And these all are the clinical evidence. First study I will talk about in 2005. It is a very prospective open study of 154 patients. Subject study was pregnant woman presenting to obstetrics and gynecology clinic, admitting center with vaginal bleeding before 13 weeks of gestation. Eligible subjects randomized to take dydrogesterone, 40 milligrams straight. Believe me, this statement will come in your mind. I will hammer regularly that whenever there is bleeding, give dydrogesterone 40 milligrams straight, 10 milligram BD, still bleeding stops. This is standard dose. Everybody agrees. Every paper will say that if you give this type of dose, continuing pregnancy was very high. P value is 0.37. And in dydrogesterone group, 95.9% percentage who received this regime has got continuation of pregnancy compared to those who don't. This is a very good second study. Again, it is a Mauritius study in 2009. Sample size was 191. Study was prospective, open and randomized. Women with vaginal bleeding up to 16 weeks of pregnancy were randomized to dydrogesterone 40 mg straight, 10 mg BD. Then specifically they excluded all the patients, those who have got history of recurrent pregnancy loss. So exclusion is there. This patient can go for pregnancy loss. Okay, the end point was continuation of pregnancy till 20 weeks of gestation. Success rate with dydrogesterone group was statistically significant higher compared to control group. Miscarriage was 12.5 in women with dydrogesterone compared to 28.4. It is almost double in a control group. So its nutshell says that if you give dydrogesterone, pregnancy is tolerated. Dydrogesterone also acts as a support in 2009 Mauritius study. It is a randomized and controlled trial again on 146 women, 20 BD, that is 20 till 20. Increased incidence of significantly lower in dydrogesterone group compared to untreated. So dydrogesterone appears to be beneficial effect in women with threatened miscarriage. Then we have a very good systemic randomized trial of 660 women. The number of subsequent miscarriage or continuing pregnancy as per randomization, woman was compared in women receiving dydrogesterone compared to those with placebo. I already says Al-Jabe, 1970 was the first paper published. As such, first paper published on dydrogesterone was in 1963. Dydrogesterone born in 1960, 9 years before I born. So it is a 1960 born dydrogesterone. First paper came in 1963, then 1970, then 1972. But it has got popularized by Al-Jabe in 2005. In 2009 we had gone to, in 2005 we had gone to India, Russia and China. There is a conference. At that time Russia, China are not using dydrogesterone as a pregnancy molecule. They are using it in a dydrogesterone. They are using it in endometriosis. And Prakash sir is there. He is the person who has introduced dydrogesterone in India. Dydrogesterone came in India as an endometriosis drug. And sir has started his presentation. I will say something that will revolutionize the treatment of endometriosis. Because this drug was basically formed for endometriosis. Now again pendulum swings. Now they are coming with 20 and 30 to use that molecule in endometriosis. They use that molecule in endometriosis in a person who has got reproductive issues. Madam, you can use dydrogesterone also. So what is the difference between dydrogesterone and dydrogesterone? If suppose this patient is of a reproductive age, mild endometriosis, want to conceive, dydrogesterone is the only molecule that doesn't impair the ovulation. Number two, it will give the ovulation, it will make the pregnancy conducive endometrium. What we mean by pregnancy conducive endometrium? This endometrium has got very good pinocodal activity, endometrium has got alpha V beta 3 intergreens, endometrium has got very good alpha V beta 3 intergreens and osteopontin. Healthy, very good endometrium. This is made by dydrogesterone. So dydrogesterone making pregnancy conducive endometrium. And even she conceived, we can continue this dydrogesterone in maintaining the pregnancy. While dydrogest is hampering the ovulation. Otherwise, both are from the same generation. If you see the generation wise, dydrogest and dydrogesterone are coming in a generation of progesterone molecule. But dydrogest suppresses ovulation. It suppresses ovulation. It treats the endometriosis by pseudo pregnancy. No menses, no ovulation. While dydrogesterone doesn't hamper with ovulation, so you can use this molecule in endometriosis also. This all study, they say that 11% of absolute reduction in the miscarriage. So dydrogesterone nutshell is very good. This is threanded trial. This trial has got nothing to do with dydrogesterone. This trial has to do with the level of progesterone. How much progesterone is less if there is a recurrent pregnancy loss or threatened miscarriage. The subject size was 1,285 patients. 665 patients enrolled in a dydrogesterone group and 620 enrolled in a progesterone treatment group. There is a very good algorithm. Those who have become a professor in medical college, they have to definitely give BCBR exam. Basic course in clinical research and methodology. Those who are in medical college, it is now compulsory. In MD exam also, they have to pass BCBR. There and then you know what is X-boot algorithm. Otherwise we are stuck with the P square, chi-square test. Okay, that is on the PSM when we had passed. But now it is compulsory for all the students to undergo this BCBR. And this is very good X-boot algorithm. It says that there is a, after 4-week treatment of progesterone group, the level of sex hormone upregulated, preterm birth decreases, postpartum hemorrhages decreases, and incidence of adverse effect were comparatively reduced. X-boot algorithm analysis demonstrated that dydrogesterone treatment was correlated with lower incidence of preterm birth, madam, progesterone postpartum hemorrhage, third, second and first respectively in various departments. There is a very good randomized control trial. If you search PubMed, Embrace, Cochrane Library, trials are included there compared dydrogesterone with placebo. Primary outcome was incidence of miscarriage. In summary, that there is what is the relative risk and confidence interval after we use dydrogesterone. The incidence of miscarriage was very lower in total progesterone group. Incidence of miscarriage is very lower in oral dydrogesterone group. Incidence was lower in vaginal progesterone group than in control. So progesterone therapy, either you give dydrogesterone, either you give micronized progesterone, but give in a full therapeutic dose. There are 2 papers given by this Alembic company to you. One paper is on luteal phase support and one is Cooksey position statement. In that we specifically say that if you want to use micronized 400 milligram BD. There is no role of oral sustained micronized tablet. There is no paper available on oral micronized tablet. There are papers for vaginal micronized because action at the site. If you put dydrogesterone or if you put micronized vaginal tablet into the vagina, the efficacy is very high. Here if you want to give 400 milligram BD, don't give 100, 200, 300, that is not the standard dose. If you want to use dydrogesterone for threatened abortion, use 40 milligram state, 10 milligram bleeding, still bleeding stops. This is novel approach. This is very good prospective cohort study. Very busy slide, so I will explain in this. Total 1,817 patients. Among 77% has got serum progesterone less than 35 nanomole, and this is nowadays worldwide accepted that lower level of serum progesterone less or equivalent to 35, they are treated with dydrogesterone, you will get very good result. This is all guidelines. If suppose I am saying this is good, no. If you say worldwide, ASHRAE 2020, dydrogesterone is probably recommended for the cases of luteal phase support. Daily dose 30 milligram. Foxy position statement. You have got this Foxy position statement with you. Threatened miscarriage, again hammering. 40 milligram state, 20 till bleeding stops. European Society Club use progesterone in miscarriage. Cochrane database says treatment with oral progesterone. Oral progesterone available worldwide only is one drug, that is dydrogesterone. Otherwise, no oral preparation give you the efficacy, give you the progesterone level which will sustain in blood. There is no role of oral micronized progesterone. I am speaking on this stage with lots of paper. Okay, so use dydrogesterone. Royal Renzoc Society says progesterone supplementation is good for threatened and miscarriage. GCP guideline 2020 also says if there is history of miscarriage, you have to start progesterone. If patient take history of one miscarriage, even you don't know the reason, might be chromosomal reason, but if you prophylactically start dydrogesterone, then there is no harm. If dydrogesterone is not needed, it will excrete. It won't harm your embryo. It doesn't give embryo pseudo-hermaphroditism like hydroxyprogesterone capriate. If you give this, there may be a change in the external genitalia. This is Foxy position statement, and I am happy that Suchitra Pandit, Amit Patki, and my friend Prakash Trivedi has introduced me to the Foxy, and I am one of the part of this Foxy position statement. Let's few talk regarding the recurrent miscarriage. I will finish within 5 minutes. 40% are unexplained. We all know we can't change genetic factors. Adam had told XR10, XY, we can't change anatomical factors, autoimmune, infection. But this 40 to 50% of cases in which we can do something. Why oral dydrogesterone is used in pregnancy? Because it does not suppress the pituitary gonadal axis, help in circumvent the inconvenience and discomfort with intravaginal or IM injections, high bioavailability, causes endometrial transformation at the dose of 20 to 20 times lower. We want to use micronized 400 to 800. Here dose is 20 milligrams. Okay? Minimize side effect to reduce the altered liver function, high sensitivity for progesterone receptor. I am happy to share that this paper was published in 2016 and it is recommended worldwide. This is the paper this company has given to you, that progesterone supplementation during luteal phase support. This study came in 2016, so up to 2016, 1980 to 2015, we have searched all the papers, 27 original research articles, 31 clinical trials, in which we had compared that if you use micronized and if you use dydrogesterone exhibit overall higher ongoing pregnancy rate compared to micronized progesterone with decreased birth effect. There are paper came in market that dydrogesterone can cause cardiac defect. Now you see that paper is not available on net. But that paper was published on a subject, those who have got cardiac disease already. Suppose 35% of cardiac disease is there, and out of 35, 2 of mother has taken dydrogesterone. It doesn't mean that dydrogesterone causing cardiac. More than 600 publications are there of dydrogesterone. More than 10 million babies delivered till date of dydrogesterone. Till date, we don't find any congenital anomaly. Why? Because it is the same retroprogesterone that body makes. So we concluded that if you want to use in IUI, there are very good results. It is non-inferior in IVF. Because when we compare that Lotus 1 and Lotus 2 study, it came by Grisinger. At that time, micronized progesterone was running very well. So if you want to compare anyway and to anyone, you don't say I am superior. You have to say that this drug is non-inferior to the existing drug. And they had proven with Lotus 1 that is world first double-blind, double-dummy study. If you see that is prospective study, randomized study, double randomization, this is a double-blind, double-dummy study. So patient has put vaginal tablet as a placebo and patient has taken dydrogesterone also as a placebo. So all these 1,716 patients are on both the drugs. Even the researcher doesn't know who is taking dydrogesterone or who is taking nitrogen. And they compare result and they found that dydrogesterone is non-inferior to micronized progesterone. That's why worldwide now dydrogesterone is available, and we have to thank that what you call the something bar. So only one company is producing now. We have got what we call, madam, the
IPR.
IPR. The only one company is producing, that is proprietorship. Now, so proprietorship is divided, and there are so many partners. And I'm happy to say that more than 87 companies are using our paper to publish that. After publishing in 2016, this paper was asked by American Library that 500 copies you should give to us. This is the immunomodulatory effect designed by Professor Raj Raghupati with increasing dose of dydrogesterone, increasing PIF that induces cytokine activity, shifts from TH2, reduces natural killer cells, shifts from TH1 to TH2, provides systematic immunomodulation and protects the fetus as it expresses foreign to maternal antigen and allogenic immunity or allogenic response to paternal antigen. That question was given by Professor Raj Raghupati. So we have to thank them, and recently had published paper on preterm labor also. Evidence supporting that how long you have to do dydrogesterone. If you see in my YouTube, you can find so many presentations of 20 till 20, and today there is 2020 World Cup final also. So why not use this 20 in my gynecology? 20 till 20. 20 milligram of dydrogesterone till 20 week of gestation, and this is not me saying, this is said by Professor Howard Karp, and Howard Karp has given his life for recurrent pregnancy loss, and he says that based on data from recent systematic review and meta-analysis, oral dydrogesterone has been found to be effectively enables pregnancy to continue even with threatened miscarriage. 47% reduction in the odds with miscarriage ratio in dydrogesterone use compared with, even though we don't say don't give bed rest, but people will take bed rest. Out of them, when there is threatened abortion, if you don't say don't take bed rest, mother-in-law make her to take bed rest. Otherwise, that same mother-in-law says that you do the work. Once there is spotting, then mother-in-law says take it. Beta, tu आराम कर, tu आराम कर. क्योंकि मेरे बच्चे की जान अंदर है. Tender loving care. Tender loving care. That is given by the husband and some part given by the male gynecologist. So this is Professor Howard Karp. Every time, whenever if you meet him in X-ray or ASCOG, always listen to you. He always guide you because he is working totally on the recurrent pregnancy loss. And some time before, one company has given very good yellow book of recurrent pregnancy loss published by Professor Howard Karp. So this is all evidence suggested that these are the causes of recurrent pregnancy loss. We all know, don't going into that. These are the suggested plan that what you can do. Everybody knows genetic you can't take, but thyroid you can give thyroxine. If there is hyperthyroid, you can give PTU. If there is diabetic, you can give metformin. But there is allogenic immune response, give dydrogesterone. So progesterone is essential for implantation and maintenance of pregnancy. Progesterone, defect in corpus luteum impairs progesterone production. However, LPD cannot be diagnosed during pregnancy. Consistency, short luteal phase is most reliable diagnostic criteria. This is oral dydrogesterone double-blind randomized placebo-controlled study at done at Medical College. The woman with either history of idiopathic recurrent pregnancy loss in either dydrogesterone group or placebo group. 20 milligram till 20 confirmation of pregnancy outcome measure was occurrence in the pregnancy loss, and they concluded that use of dydrogesterone in women with recurrent pregnancy loss to improve pregnancy outcomes such as reduction in abortion, improve gestational age, baby weight. This is one of the additional findings that we don't consider that with dydrogesterone there is increase in birth weight also. So this is additional finding coming from this. This is effect of immunomodulation and systematic review, 13 studies, total 2,454 patients. In experimental group treated with dydrogesterone, gonadotropin and placebo, dydrogesterone has got higher pregnancy rate, success rate rather than control group. Also that dydrogesterone has higher level of interleukin 4 and 10 than control group with level of interferon gamma was very lower. This is again meta-analysis of all this search engine, 15 randomized controlled trials, 666 patients reported on threatened and recurrent miscarriage. And we have to proudly say that Dr. Prakash Trivedi has also done meta-analysis in 2005, and that also published in meta-analysis. He has done study on dydrogesterone. This all different study. The odd ratio, if you see, this is a positive. This odd ratio favors dydrogesterone. So they concluded that increasing risk of pregnancy loss, progesterone probably increases the live birth without increasing adverse maternal outcome and neonatal events. It remains possible that benefit is restricted to those with prior miscarriage. So 10 milligram BD, 20 till 20. Today is World Cup final. So remember, whenever there is threatened or recurrent miscarriage, use dydrogesterone up to 20 weeks of gestation. Usually placenta can take care function after 3 weeks of gestation. Because of improper presentation or hypopresentation, progesterone might not reach to the site. Give this benefit of 20 till 20. So in summary, spontaneous pregnancy loss is very common. Approximately 15% of all clinical recognized pregnancy result in miscarriage. Whenever there is RPL or recurrent pregnancy loss, defined as 3 consecutive pregnancy loss prior to 20 weeks of gestation, last menstrual period, individual protocols approach, create, identify and correct any modifiable risk as well as offering appropriate psychological support that madam has rightly told, tender loving care, usually by the husband, SAS, husband, and small part is taken by me and Prakash Bhai as the male gynecologist. He said that, baby, don't worry, it will be fine. If you want to cry, there is one head, there is one
shoulder.
One shoulder.
You will answer.
No, my wife will make you drown, make me drown, so don't worry. In case of the one explained RPL, progesterone has to be beneficial, decreasing the miscarriage rate. Patients and physician can be encouraged by the overall good prognosis, as well after 4 consecutive losses, patient has got higher than 60% or 65% chances of next pregnancy to term. So your work has been appreciated by company. If you are doing this, all are the GIF made by company of different companies. And lastly,
the time to be happy is now, and the place to be happy is here, and the way to be happy is to make someone happy and have a little heaven right here.
this is simple nursery rhyme. You can all recite.
The time to be happy is now, and the place to be happy is here, and the way to be happy is to make someone happy and have a little heaven right here.
So thank you, Locks, for giving me opportunity. These are the 2 QR code scanners. This scanner is of Orchid and this is of YouTube. In Orchid, you can find my 114 publications. So if you want as a reference, or if you want as a stimulator, or if you want as an igniter, start producing papers, because worldwide your money doesn't count. Your paper, your publication.
I'll call you back.
counts. Okay, so
I'll
thank
call
you
you
very
back.
much.
I'll call you back.
Thank you, Manish.
One last thing. Just. नहीं मैडम, एक बस एक स्लाइड आप लोगों के लिए ही है. This is for Dr. Preeti Kumar.